The overdose problem is actually solvable. It's one of the biggest public health problems that we have a solution to.
Let's go! Ben ye for assembly. Ben ye for assembly.
Hi, everyone, and welcome to Bold Ideas with Ben, a weekly podcast where we talk with people who have bold ideas to reshape our community, politics, and government. Thanks so much for joining today. It's a real honor to have you on, and I appreciate you taking the time.
It's my pleasure to be with you. My pleasure to sort of support you and the important work that you are doing, and we hope we'll be doing in the New York State Assembly. But
Oh, yes, I really appreciate that. But today we're here to talk about your work because you're doing some super important things too. And for folks who don't know, I'd love to just have you introduce yourself a little bit. I'm joined by Andrew Tatarsky, who basically wrote at least a book, if not the book, on harm reduction. For the folks who don't know, what is harm reduction, and where does it fit in the ecosystem of mental health?
Well, harm reduction is a set of ideas and practices that aim to reduce the risk and harm of potentially harmful behaviors. That's sort of the technical definition. But it really is important as a kind of corrective to what have been traditional abstinence-only approaches to substance use and other risky behaviors, like risky sexual behavior. Sort of traditionally, the approach to risky behaviors like drugs and sex has been to try to just get people to stop. And,
Abstinence.
Abstinence only. Abstinence is sort of the only acceptable goal of traditional treatment, traditional approaches. And it became clear in the HIV/AIDS epidemic in the 80s that approach was an abysmal failure, that, people are engaging in high-risk behaviors, they're putting themselves and others at risk. And it became clear that, putting the values of helping people stay alive and healthy above trying to get them to stop doing things was just an incredibly important paradigm shift. And that really led to the birth of harm reduction as a movement, to save lives.
Yeah. Before we get all into that, I would love to just set the stage and ask, what was help quotes, what was help like before the invention of harm reduction? How did they try to get people to stop doing things? Probably a lot through things like shaming and pushing things into the closet, so to speak.
I'll share a little bit about how I came into this work.
Please, yes.
So I'm a psychologist, and I've been working really on the front lines in the addictions field since, early in my career, since the 80s. And when I came into the field, the only approach to treatment was a disease model, abstinence-only approach to treatment. And I worked in that model for the first 8 years or so of my career. And while we did help some people, what I began to notice early on was that we were not helping the majority of people that were coming to our treatments. And when I looked around the field, I noticed that the overwhelming majority of people were not going to treatment. Those that were going to treatment were not completing treatment. And so that really forced me to really begin to wonder, what's wrong with this picture? And I think that the disease model and the basic assumption of abstinence only appeared to me to be major barriers, right? So the way that traditional treatment was oriented was that, there was a requirement that you commit to stopping in order to get into treatment, and that you are successful at stopping fairly quickly, or you're deemed not ready, not motivated, and discharged from treatment. So I began to, it became increasingly disturbing to me that we were actually blaming the patients or, holding them responsible for the failure. I mean, just consider the absurdity of discharging people from treatment for the problem that they're coming to treatment for.
Right. It's like if you don't get better from, having cancer, you are a failure. So you're forced out of the program where you would get treatment for your cancer. We would never consider this to be a realistic expectation of any other form of help.
So to go back to your question, sort of that approach is kind of psychoeducational, teach people about the disease of addiction,
Hmm.
and sort of in one way or another get to accept their disease and their powerlessness, and then commit to stopping. And the data shows, and this is more true today than ever, and more glaringly true with the opioid overdose, epidemic,
Hmm. Yes.
that's an ineffective way of helping. And so that actually forced me early in my career to begin challenging the tradition and breaking all the rules. That is, accepting people into care on their own terms, around their own goals, their own motivation. And lo and behold, actually, I discovered that works. And then I had the good fortune in 1994 to have a relationship with a giant in the addictive behaviors field, a guy named Alan Marlatt. And I called Alan up and I said, what's going on here? The traditional approach isn't working, breaking the rules is. And he said, Andrew, you're doing harm reduction. So that introduction to harm reduction as a philosophy for guiding or framing, containing treatment really set me on a journey of drawing out the treatment or therapeutic implications of the harm reduction model. And that's really what my work has been all about.
Now, just to be clear, this fellow knew exactly what it is that you were doing. Why hadn't it become a thing at that point if he's a giant in the field, and he knew what you were talking about and he knew that it was effective and he knew that when you explained that this is working and the old model isn't working, why wasn't that already, that success story already translated into action?
Well, in 1994, harm reduction was largely unknown in the United States. It had been born in England and the Netherlands in the late 80s. HIV and AIDS activists were bringing harm reduction over kind of as a grassroots movement to the United States, because at the time, people that were IV drug users and were engaging in high-risk sex were dying like crazy. And so this grassroots movement emerged of folks kind of helping one another stay alive and healthy. But it really, in the early 90s, it hadn't become widely known, which is now actually in this current age of opioid overdose epidemic. That I think has now, over the last maybe 5 or 10 years, sort of forced the field, the treatment field, to open up more and more broadly to a harm reduction philosophy.
Now, I do want to talk about in a moment exactly why there was such recalcitrance and why it is that the opioid epidemic was the impetus. But obviously, you're a huge proponent and I'm a huge proponent of harm reduction. But for the folks who aren't convinced, how much more effective is it? Why does it work? And what sort of successes have been seen with harm reduction over the previous models?
Well, in terms of its public health applications, clean syringes, that is syringe exchange or the distribution of clean syringes, has been available. We have had the lowest HIV/AIDS conversion rates and deaths. So there's been tremendous support for the idea that public health harm reduction has been one of the most effective public health interventions in history. What we've now seen more recently, an increasing embrace and support for Narcan distribution, which is the medicine that reverses opioid overdose, is that it has been more and more widely distributed around the country. And many believe that it is one of the most important factors in a significant decline in overdose deaths over the last 3 years or so. There had been 20 years of increasing deaths from overdose over 20 years that amounted to over 1 million folks dead from lethal overdose and drug poisoning. And in the last 2 to 3 years, there's been a significant decline. Now, that's been wonderful, but nonetheless, 80,000 deaths a year is still a terrible number. And unfortunately, we see in communities of color and lower income communities, there has not been that decline. So we still have a lot of work to do on the public health front. In terms
Nope.
of psychotherapy and substance use treatment, there has been very little empirical research because the government has not been favorable toward harm reduction research, and that was before Trump. And
Mm.
now it's become, the Trump administration seems to have it out for harm reduction.
Yeah. Now, why do you think that is? What is the resistance of particularly government to things like harm reduction, and why do we see it why do we see certain communities not benefiting from its tactics as much as others?
Uh,
A big question, I know, but
the government's drug policy, prohibition,
right, the
the
war on drugs and all
criminalization
that.
of drugs, and the overemphasis on incarceration rather than treatment has been part of the American drug policy forever.
Going
And
back to alcohol, right? It was the number
that,
one thing
well,
America always
after
tried to ban it.
alcohol, actually after alcohol prohibition, the government agency that had been responsible for overseeing alcohol prohibition had nothing to do, and so it actually switched its focus to drugs.
Hmm.
Drug prohibition was driven, I think, by political need and economic forces.
Hmm.
That was made explicit under the Nixon administration when his crew said, prohibition was explicitly designed to give the government a way of going after its political enemies and Black people.
Hmm.
So racism has also been a driver in the criminalization of drugs. So now we have this huge criminal justice system that is supported by the criminalization of drugs. So you've got these multiple factors. And then you've got a treatment industry that has been dominated by this abstinence only ethos, which actually fails to help most people, but nonetheless, it feeds off of, this kind of prohibition mentality in treatment.
Yeah, it supports the political aims of a government that wants to focus on prohibition and criminalization for
Yeah.
other reasons.
But I did want to cite a piece of evidence that I'm quite proud of that
Please.
I think supports the efficacy of harm reduction in drug treatment or in psychotherapy. I founded and ran a center called the Center for Optimal Living for 12 years. And it was a psychotherapy center organized around my work, Integrative Harm Reduction Psychotherapy, meeting people where they were on their own terms, supporting any positive change. And I think that really was the frame for all of the work that we did there. Over those 12 years, we did not lose one patient from lethal overdose. And this was a center oriented toward people with problematic drug use. And we didn't drug test people. So the harm reduction frame really lends itself to strengthening collaborative therapeutic relationships. And that really is the foundation of all effective healthcare.
Yeah.
And so I think that is a body of data that really stands to support the value, and I even think the essential value of this kind of approach in.
Yeah. So digging a little bit deeper into that, actually, I'm curious to hear over what time frame was that? How many people? You mentioned that nobody was lost to an overdose, which is
Mhm.
absolutely fantastic. How does that compare to traditional methods? And then how did you see anything in terms of reduction of drug use overall as well? Not just overdose reduction, but reduction of use.
Well, absolutely. We opened in 2011 and we closed in 2023. So that was our 12-year period. First of all, the program prospered because of our success. People were there because they were motivated to make positive change in their substance use and their mental health issues and behavioral issues and so on. Our patients got better in terms of cutting back their substance use to safe, non-problematic levels. In many cases, people stopped using. So actually,
Incredible.
abstinence is one possible harm reduction goal for folks. People don't typically start with a commitment to abstinence, but a harm reduction therapy approach is designed to support people in discovering what their healthiest ideal relationship to substances is. Um, and I think because of the success of our patients and the word got out in New York City, we had an expanding community of uh, former clients, of healthcare providers, of other psychotherapists who were referring to us. And that led to the growth. We closed on a high point. We had 300 patients.
Wow.
And the reason we closed was really, it was sort of time for me to kind of let go of the responsibility so I could really focus on consulting and training, which is what I'm really putting my energy into.
You talk a lot about meeting people where they are and all of these things. Can you tell us a bit more specifically, what are the tactics that are employed in things like in harm reduction and at centers like the ones that you ran?
So I like to think about the core principles of harm reduction as a frame for helping relationships. One of them is what Alan Marlatt, who I mentioned earlier, he coined the phrase compassionate pragmatism,
Mm,
meaning, compassion is our commitment to supporting people and reducing their suffering. But the pragmatic part is really key. That is, we have to actually do what works, not what we believe ideologically. And so harm reduction is at its core about figuring out what's going to work with this group of people, but with this particular individual in this particular moment. So it's very much about collaboration with the participant, with the client, working together to really figure out what's going to be most useful for that person.
mm,
And then consider the principle of starting where people are rather than where we want them to be. So that means that, we invite people into care wherever they are around their goals as a starting point, their motivation. And we really, truly individualize, start where that person is. Um, then this another kind of core principle is any positive change. So
mm,
let's say we start where people are, and that becomes kind of the glue or the point around which we can establish our alliance, our therapeutic alliance. Then we can begin collaboratively goal setting. What are positive steps that people are able, willing, wanting to take on, which could be as small as simply showing up and beginning to take a closer look at themselves. So establishing that relationship, that alliance, working collaboratively, creating safety, I think is the sort of foundation. Then within that framework, we can work together to collaboratively assess, you know, what is, driving this problematic behavior. And I
mm.
think that that's one of the keys to the shift. In the old abstinence only approach, the idea was to stop the behavior and then figure out what's going on. In a harm reduction framework, we recognize that behavior is driven by complex meaning, function, habit, biology. And so to ask people to give up their behaviors before we've really helped them understand and identify what's driving it is a setup for failure. So I have this idea of assessment as treatment. We work together to sort of figure out what are the key factors, that are driving that behavior. And as we can begin to identify them, we can support people in developing alternative, healthier, or less risky ways of caring for themselves. And that then is going to shift people's relationship to the problematic behavior and increase their desire, motivation to cut back or to stop or to use more safely. Um, so I think another key is what I call embracing ambivalence. You
Mm,
know, if your substance use is actually helping you cope, function, manage emotional distress and so on, it's serving a vital function, right?
right.
Even if another part of you recognizes that it's causing harm or potential harm. So people are going to be understandably ambivalent about change. So we want to invite the ambivalence in, help people get inside of that desire to use, again, so that they can recognize how it's functioning, what it's doing for them. And
Right.
then we can talk about alternative solutions, which then support the part that wants to change.
Right. Because it becomes very difficult to change people's behavior if the motivations remain the same. Unless you unpack the motivations and you disrupt the negative incentive structure, then why would they change their behavior? Because actually they have a deep-seated motivation or an incentive to do a particular thing. But if you don't remove it, then they must find some way to meet that need.
That's right. And then I think the final thing is, once we've really gotten clear about the motivation and maybe some new ways of coping or caring for oneself, I think about that as new goals.
Mm.
Then we can work on helping people design a comprehensive plan and strategy for working toward those goals. And that can include, all sorts of things. But basically, I think arming people or supporting people and shoring up their capacities to regulate, uncomfortable feelings, identify urges, stop the action around urges, and kind of think through, pros and cons of acting on the urge or not.
Right.
And then having a clear sense of, the alternative kind of healthier repertoire, and then people can put that into practice, and over time, that becomes the new normal.
Right. So that might be some of the more traditional things that people think of in terms of like social cognitive skill building, where you're able to label feelings and then instead of impulsively acting on them, make conscious decisions about how to respond to that. And maybe if you're using a substance to ameliorate some feeling of distress or anger or hurt, to find a different coping mechanism.
Absolutely. And so, a lot of the skills and kind of thinking in traditional treatment is not necessarily wrong.
Mm.
It's just that abstinence-only treatment is overly limiting to people who are ready, willing, and able to commit to or work
Right.
toward abstinence. What the harm reduction work does is it opens the door to everybody else.
That's right. Yes.
I wrote a paper in 2010 called Harm Reduction Psychotherapy, Extending the Reach of Traditional Treatment.
Yes.
And I think that's really important for traditional treatment people to consider. We don't need to throw the baby out with the bathwater. We don't need to dismantle traditional treatment for the people that it really is helping, but we need to extend care to people that are not ready, willing, or able to commit to abstinence, and open the door wherever they are ready to kind of walk through.
So if I understand what you're saying, it's sort of like you have all of these tools and maybe the tools have been used in the past and some of them indeed do work, but unless you're ready to commit to abstinence, you will not be given even access to the tools. And harm reduction is flipping the script. It says, here are all the tools. Make use of what you can. Get yourself to a new stage in your relationship to whatever substance or behavior it is that's harmful. But why would you keep people from the tools that are helpful by making some extreme request, which is maybe even the end stage? Why would you make people commit to the end goal and achieve the end goal before even having the tools?
Absolutely. And you know what, I think about the analogy of wanting to start an exercise program.
Right.
Imagine if you went into a gym and you said, I'd like to get healthy. And they said, okay, we'd love to sign you up. And in order to, join the gym, you have to commit to 5 exercise classes a week and 3 strength training classes. And you have to commit to run the marathon in 6 months. And we're going to get you ready to do that. And we can guarantee that if you work the program.
Yeah.
How many people would sign up for that gym?
Right. And they've got to do the marathon at the end of it and all this time. Like, yeah, I feel like most people will probably be like, never mind, I'll just try to work it out on my own.
Yeah. So what they do, though, you walk into the gym and they sit down with you and say, well, let's discuss your goals.
That's right.
And let's see, let's do a fitness assessment, and then let's design a program that starts where you are.
It's basically, honestly, it is the exact same. It's just common sense. It's like, every sales routine ever doesn't start at the end, give me $1 million. It's like you work them up and you meet them where they are. And, certainly, there's all these things like land and expand in sales parlance, just like, just do a little bit. And then, you coax them along. And every single, I feel like, human interaction aside from, substance use recovery or like whatever it is, harmful behavior work, understands this intrinsically. You
Yeah.
don't never ask for the maximalist thing up front. You build people up, and in organizing, it's called, a ladder of engagement. You take people from one step to the next as they become more and more invested and they see results. So it just seems insane that this would be something that hadn't been applied before.
Yeah. It occurred to me one day that we don't need to know the destination to begin the journey.
Yes.
The most important thing is, how do we help people or support people on their journey?
Now, I am curious, how do folks get into harm reduction? Because, we have, one of the things that I hear running for assembly, and I'm, on the streets talking to voters and what have you, is, oh, there are people who need help, and how do we get them into help? And insofar as folks are met where they are and they have intrinsic motivation, does harm reduction rely on people, say, coming to your center? Or is there some proactive outreach? How do people get into a program that can actually help them?
I mean, I think the major push has been to educate professionals, to educate the public, to sort of change the paradigm. It's what most professionals have been trained in, or mental health professionals have not been trained, because part of that old paradigm is that, an addict needs to go to an addiction specialist in an abstinence-only treatment program, and they need to get sober before they can be in psychotherapy.
Yeah.
So a lot of mental health professionals have bought into that, and they think that they can't help these folks. I should add, it's respectful, it's compassionate, it honors people's agency and sees people as having expertise in themselves. And I have to say one other thing, that it's also really about love. More and more people talk about love, just meeting people with genuine care for their well-being, without conditions. The only condition is that somebody wants to show up and be supported, in working toward, greater health and quality of life, and as they define it.
Amazing.
Somebody might say that is basically a definition of love.
I would agree. Now, we had mentioned a little bit earlier about how some of the traditional methodology around abstinence and all of this came out of the government's desire to maintain what was before an abstinence culture around alcohol and prohibition. And I'm curious to hear from your perspective, what today would be the role of government in helping promote harm reduction, or how can the government be better involved in helping people who have behavioral health issues?
These old ideas have also been institutionalized in, as we've said, putting more of an emphasis on criminal justice interventions rather than treatment, maybe supporting abstinence-only treatment rather than harm reduction-oriented treatment. Government's role could be to really support kind of the retraining of the workforce.
Now, I'm curious, you had mentioned that this concept had really come over from Europe. So they're a couple of years ahead of us on experience with this. Have they gone all in on this? What are we seeing over there where it's been tried for even longer and maybe at larger scale?
Europe was way ahead of the United States. I guess still is way ahead of the United States on the public health front. Unfortunately, on the treatment side, and I've had the good fortune to train internationally in places like Portugal, which we know of as having one of the most progressive drug policies in the world, if not the most progressive. and being quite supportive of harm reduction. Nonetheless, there's a split, which is still largely the case here in the United States, between kind of harm reduction programs on the ground, programs working with more marginalized populations, doing public health harm reduction and some harm reduction therapy, and traditional treatment, which is still largely dominated by the same abstinence only approach that dominates in the United States. So, I think one of the things that the United States exported, and the US likes to export its ideas. One of
Through
them
any
that was
means
exported
necessary, often.
was this idea of abstinence only treatment. This paradigm shift that needs to happen or is happening is a global movement. And this is something that has been, also a tremendous gift for me to be connected to a global harm reduction movement of forward-thinking, heart-centered people all around the world that are doing the work that I'm doing and our colleagues here in the US are doing. And it's an amazing group of people to kind of connect to. So
that is great to hear. Now you had mentioned the opioid epidemic earlier and how this sort of the transition to harm reduction was accelerated by the opioid epidemic. And I'm curious to hear why you think that is, what the factors at play there are, and whether there is legitimate. You also mentioned the Trump administration, and of course they're just they have no real experts on any subject and they're simply backwards. But insofar as there is true resistance to transitioning to this model, why does that exist?
Let's think about the 80s or into the 90s with the proliferation or wide prescribing of OxyContin. And then there was, the brilliant DEA or, Office of National Drug Control Policy decided to crack down on opioid prescribing indiscriminately, so that many, many people that were dependent on prescribed opioids were suddenly without their prescriptions. And what did they do? They went to the black market, and many of them discovered heroin. So, that led to kind of a wide or growing epidemic of heroin use amongst less traditional drug users, largely white drug users.
Right.
And then as the government started cracking down on heroin, fentanyl came in, right? So, but I think it was the shift in the demographics from, a less white drug using population to a more white drug using population, so that now drugs are infiltrating, or the drug problem and the overdose epidemic was coming into wider, more affluent communities. And that then became, unfortunately, it took that to become a catalyst for a wider embrace of harm reduction.
I suppose possibly for two reasons. The first one being it affects more people, so they need to take solutions to it more seriously. And then probably that more affluent, wider communities are not interested in the criminalization of their behavior, but instead more compassionate forms of care.
That's right. And some people that are more knowledgeable about this than me have argued that the traditional, more punitive, abstinence-only treatment system, in effect, was largely designed for poor communities of color, and so the larger community didn't care so much that, that they weren't working very well. They were sort of like revolving. Fortunately, it takes an epidemic, and it takes an epidemic that, affects, the dominant culture or communities to shift things, just as it did, with the HIV/AIDS epidemic in the 80s.
Right. Now, speaking of those marginalized communities, we had touched on this a moment about what the government can do. And of course, a huge part of that is professional development and education for folks in the field and funding for training programs. But I'm curious to hear how you think things like harm reduction intersect with policies like housing first for the unhoused population and other things that we can do to deal with some of the folks in our society who are, both on the margins, but are also sort of front and center in debates on things like crime and safety.
We could say that there are 4 pillars of harm reduction in the United States. The first one we've talked about, public health.
Hmm.
The second one is housing first. And the housing first movement is a movement that basically says human beings have the right to a safe place to sleep that should not be dependent on their drug using status. What housing first folks in terms of data have found is that when you give or make a safe place to sleep available to folks, without any other intervention, their mental health tends to improve and their substance use problems tend to diminish. It makes sense. If you think about substance use not just as the disease within, but as a reaction to difficult life circumstances that create tremendous suffering that people need to cope with. So
Yes.
if you change the life circumstances, the suffering diminishes, and people's need to use substances tends to diminish. New York City has been at the forefront. I think we have more of these programs here than I think anywhere else in the country. Now, the most controversial, but maybe most wonderful expression of harm reduction right now in the country is On Point. On Point is a harm reduction program that also offers medically supervised consumption. People can bring their drugs into the center, use them under medical supervision, and then have a place to hang out. And if there is any kind of medical emergency, they have medical staff there to care for them. Now, one of the biggest criticisms, which is an ignorant criticism, a misinformed criticism, is that harm reduction is enabling. Aren't we enabling the disease? Aren't we just enabling people to get high? First of all, harm reduction enables people to stay alive.
A big win, I would say.
Yeah, supervised consumption sites have been around for 40 years around the globe. Get this. Millions of supervised injections, not one lethal overdose. The overdose problem is actually solvable. It's one of the biggest public health problems that we have a solution to.
I do find it to be absolutely incredible how effective these sorts of programs are, but how little support they seem to get from the public. I'll never forget, I used to work for the New York State Senate. I worked in state government. And one of the things that we would do in my unit, which was for the chief information officer. So we were doing most of the technology for the New York State Senate. We were doing all of this technology, I should say, is we would go look at what other states were doing. And so in my researching of technology things that other states were doing, I came across a state that had, purportedly solved the unhoused crisis in that state. Utah, Republican state, Republican governor. And it was incredible. And I just kind of looked into it, and the solution was, as you said, unconditional housing. They just gave housing to people and it solved the unhoused problem. And suddenly they didn't have people who were opting to spend time on the streets. And it was bonkers to me because here I was in New York State and we weren't doing anything close to this. It wasn't even part of the debate at the time. And here was a Republican state who was they were just like, well, we're fed up with this problem. So we'll just give people, not glamorous homes, but some sort of safe place to sleep. And to the extent that these were comfortable places to go, folks opted into that. And so we could be doing that sort of thing. I wanted to just ask you one more question, because you had mentioned 4 pillars of harm reduction, and we've really only talked about 2 of them. What are the 4 pillars?
Okay, so public health, housing first. I think solving the drug war. I think it's arguable that, the war on people who use drugs, or prohibition, the incarceration of people who uses drugs, is possibly, I think arguably, the greatest harm associated with drug use for individuals, their families, and communities. And I think if we took all of those resources that we put into incarcerating and punishing people and put them into this whole range of services that would improve people's lives, we'd have a lot more of an effective, system for caring for folks. So that's 3. Although I must say that every harm reductionist doesn't necessarily agree with me, equating, ending the drug war with one of the harm reduction pillars. But I think that that's just a no-brainer. Just one comment on that is that I think that the more that we've spent on criminal justice, the more we see that it doesn't do anything to
That's right.
reduce the drug problem or protect vulnerable people from drugs.
We put so much
again,
money into it for like nothing out of it.
I saw one graph about, before cannabis was legalized, the more money that was spent on cannabis prohibition, the more cannabis use there was in the country. I mean, a correlation. But so that's 3. And 4th is treatment. Capturing the phrase, any positive change is what should really characterize the entire continuum of care for people that struggle with drugs and other risky and harmful behaviors.
You're a leader in this field. You're a big proponent. So you've worked with state governments. You've consulted with large hospital networks to try and get them to adopt these practices. Is that right?
That is right. And there's a lot of positive change happening. I've trained in 20 countries. Despite the fact that there's a lot of work to be done, I think there's a lot of reason to be hopeful because while, this paradigm shift is still happening and needs to happen in many places, it is really moving through the grassroots in the professions and also in many local and state governments around the country and around the world. So that leaves me feeling extremely hopeful.
Fantastic. And you mentioned as well that there's a lot of free resources on your website. So do you want to just mention what your website is for folks who might be listening?
Sure. AndrewTatarsky.com. I'm doing a number of trainings, and there is a recorded training that people can find on the. I created a 15-hour full-on basic training in my approach that has recently been recorded, and that's available. People can access and work through on their own time. I do consultation groups, and a bunch of my publications are available for free. My book is not free, but it has been translated into Spanish and Russian, and the PDFs for that are available for free. So,
amazing. Can you tell us the title of the book?
Yeah, the book is entitled Harm Reduction Psychotherapy, a New Treatment for Drug and Alcohol Problems.
A fantastic book. If you're interested in this subject, you should definitely check it out. And certainly if you are somebody who provides care, worth the read. And of course, visit Andrew's website. Andrew, thanks so much for talking today. This has been just a fantastic conversation. I really appreciate it.
Thank you so much, Ben, for giving me the opportunity to share with you and with the folks out there.
Amazing. All right. Thanks again, and I'll see you soon.
Okay.
All right. Bye. If you'd like to find out more about me, Ben Yee, and my campaign for New York State Assembly, check out my website, votebenyee.nyc, or any of the social links below. Like and subscribe, and check us out next week on Bold Ideas with Ben.